Thank you, everyone. It is an honor to be here presenting this work. On your schedule, it says Dr. Jennifer Young. I am not a doctor, not until next Friday when I defend my dissertation, but very soon. This presentation represents just a very small portion of my dissertation, and I've been so grateful to work with the families at the National Cancer Institute, and I'm excited to present some of the data that really piqued my interest about the individuals with LFS and the people that they're married to and how this has really affected families. So today, and a little bit of background about me. I am a pre-doc fellow, a pre-doctoral fellow at the National Cancer Institute. I'm also a licensed marriage and family therapist, so I really like to focus on family dynamics, family processes, and coping in those systems. So Dr. Payal Kinsha and Dr. Sharon Savage have already touched upon some of the study aims that we have, but today I'm going to focus more on the psychological and social functioning of our patients. And I'm not going to go into too much depth about the screening because other people already have, but just to point out that this is not a small amount of work for these families and these individuals. And so although it wasn't the intention of my study originally to look at the impact of screening, it came up a lot in my talks with the families. And I was so happy that Claire presented before me. I've really looked up to her work, and you know, similar to what she had pointed out, there was a recent study that talked about how LFS patients looked at the drawbacks and benefits to screening, and these are some of the examples that they pointed out. Similar to what Claire had mentioned, there are some logistical issues, difficulty navigating the system. It's quite draining to do the screening, and there are also some distress and emotional reactions that people have as they're going through this process. But patients did say that the benefits outweighed the drawbacks for them. They really were committed to the screening because it gave them a peace of mind. It was centralized, and they really viewed knowledge as power, which I've heard so many times in this conference. And there are other studies that have really showed that family and social support do help in the adherence to screening, as well as coping with the kind of chronic burden of living with the potential of cancer. But these patients feel some guilt regarding the adverse impact on their relatives, and they feel responsible for decreasing the emotional burden. There's one study that looked at couple distress, and they found that when there was higher levels of cancer worry in the person with LFS, this was also kind of reflected in their partner's distress levels as well, so both kind of going upwards. And a lot of patients have pointed out that they're not the only ones who need support. Their family members, their spouses, everyone else in the family needs support as well. But we really have limited evidence as to how these couples are coping with this stress and this worry about cancer. So a little bit about kind of the marriage and family therapy world. So I take a family systems approach to everything that I do. I believe that people cannot be understood in isolation, but rather in the context of their social support networks. And also, I really love the medical family therapy approach, which integrates kind of team-based interdisciplinary research and clinical approaches using many different people and kind of different, like a collaboration. In addition, this presentation also looks at the family resilience and how people have this kind of innate ability to repair and to grow from very challenging situations. So the main research question that I'll be talking about today is how do couples in which one partner has LFS cope with their own or their partner's high risk of cancer? And so I did in-depth qualitative interviews with couples to assess the different coping strategies that they were using, and I really focused in on the couple dynamics, their communication, as well as how they view these challenges as shared or independent. Again, a little bit about the screening study. We do a lot of work, just kind of like, as Sharon mentioned, with the screening, but also we evaluate the psychological and social functioning through two different approaches. One is the colored ecogenetic relationships map that June Peters has developed, and Renee Bremer. If you have any questions, June is already headed back to DC, but Renee and Megan are both experts in that. And then I do the family interviews. So if anybody comes to clinic with one or more family member, then they're invited to participate in this part of the study. And some of the questions that they will be asked are, can you tell us the story of how you became aware of the P53 mutation in your family? Is there a traditional way or family expectation regarding how mutation-positive individuals should manage their risk? And how do you as a couple support each other with regards to risk management? Lastly, as family members plan pregnancies, what issues have come up related to having a TP53 mutation? And again, although screening wasn't integrated in, like specifically mentioned in my interview questions, it came up a lot because it was the day that they were doing all of their screening. So it was very much at the forefront of their minds. So in total, I interviewed 26 heterosexual married couples. The ages ranged from 22 to 61 years. The majority were women with LFS and their male partners. 20 of the couples had the person with LFS did have a cancer history, and the majority also had at least one child. Of those people who had a child, 10 people had had their child tested, their child or children tested, and at least one child was found to have the mutation. 9 had had children tested, and none of their children had the mutation, and 4 couples had chosen not to test their children at the time of the interview. The way that I analyzed the data was using modified grounded theory, and this is kind of a cyclical approach to collecting data and developing hypotheses. And the reason that I actually decided to focus in on couples was when they were coming into clinic and I was doing these family interviews, it often was the spouse, the person without LFS that was really starting to break down. It was often the first time that they had really talked about what the experience was like for them. And so it really struck me, and this is the direction that I chose to go in. These are the different stages. So once the interviews were done, we transcribed them and did open coding, developed a code book, and refined the code book over time. And all of the transcripts were double coded. And so I'm going to be presenting some quotes from the data. All of these are pseudonyms. And so you won't recognize anybody in here. Nobody's identified. The first thing that we noticed was that there was this ambiguous danger of LFS, but that this threat of cancer really was shared by both spouses. Both of them felt this. And they both kind of feared a sudden diagnosis that might change their lives forever. And Bert, who is the partner of somebody with LFS, says, "We're both just kind of worried. After you've seen it happen, you've seen it happen to her, her father, her sister. You know where you will finish the race, you just don't know when you're finishing the race." And as I mentioned, the emotional cost of annual intensive screening was high. People said that it did promote agency, gave them a way to have some sort of control. But the trade-off was that they have this kind of burden of worry and anticipation regarding the screening results. A lot of people talked about leading up to the screening feeling anxious. And Tim, also the partner of someone with LFS, says, "We play Russian roulette once a year, but the game is never over." Something else that emerged from the data was 2 different kind of themes around how couples coped. 17 couples coped by connecting with one another and taking a very shared kind of parallel approach to approaching the challenge. And 9 of them decided to kind of cope more independently. So they were taking more of like a separate view of how they needed to tackle LFS and the different challenges that they faced. So first, some examples about the couples who coped in connection. These couples developed kind of a mutuality, and it fostered more of like this kind of emotional back and forth and support and balance. They were very attuned to each other's needs and able to kind of shoulder the burden and alternate taking turns doing that. So Liz, who has LFS, she said, "I had to accept him helping me and being the other part of me. I mean, he had just as much a stake in it, and he was my other part. And so I had to let him do what he needed to do, and I was better off for it. And I know that he was better off for it." We noticed this "we" language that many people were using, which demonstrated a shared sense of identity in their view of LFS. And Tim says, I mean, I've highlighted how many we's we have, but he is the person actually not with LFS. He says, "Well, we've been blessed with a very clean bill of health now repeatedly, and I think a part of me, knowing that we've been granted a sort of reprieve, we've been given another clean bill, not that we might not still be given one, we'll deal with whatever has to happen and the timing of that and how it affects whatever. We'll just make a plan and we'll do it." So moving on to the second typology, these partners viewed LFS more as an individual stress, and they used their own individual strengths to deal with it. And opposite to the we language, we heard a lot more I. So Bill says, we didn't really cope because she just takes care of herself. It's not my decision what she does with her body or medical, because everything I say, she's going to say is stupid or blame me or like scapegoat type of stuff. So I stay out of it. I just took care of the kids and everything else and let her try and get healthy. Another partner pair said, Lucy, she's the one with LFS, she said, I withdraw before and after the test. She says, don't give me one more thing to do. Don't mess with me until this is over, because I tend to cognitively slow down. The things that I have to do just take longer, and I just want to put everything off until this is handled. And so Phil, her husband, says, I have to deal process-wise, like what's the contingency plan? And protective buffering is a theme that's come up in the cancer and caregiver literature quite a bit. In this context, it's more about hiding the LFS-related or cancer-related thoughts or concerns from one's partner or spouse. And often in the literature, we've seen it as the caregiver of the patient kind of holding back, trying not to distress the patient any further, but we found something slightly different in our population. So this was in line with the other literature, so the non-LFS spouse hid their concerns and their emotional distress from their partner out of a sense of compassion and sympathy for their partner's position. So Gilbert says, I felt if I told her I was worried, it would cause her to worry more. I thought she had enough on her plate, and I didn't want to add to it. I couldn't let myself do that. So I went into my box and I just hid from her. His wife, Cordelia, the person with LFS, says, a lot of his struggles, because he didn't want to burden me with them, he hid them pretty well. I thought to myself, well, if I could have someone to cry with, that would make me feel so much better. So Gilbert, why can't you do this? And that caused a lot of tension between us. So the distance became even more. And again, Gilbert's intentions were good. It was out of love and caring. He was trying to protect his wife, but he was making an assumption about what she needed. And so it didn't play out exactly kind of how he had wanted it to. The thing that's unique about the LFS population is we actually found a lot that the person with LFS was engaging in protective buffering, often because they had a sense of guilt about how much they were having to do, how many doctor's appointments there were. And so Jessica, this is before she had the testing, she said, I pulled back and stopped talking about it because he was under a lot of stress. And he never asked me to. I probably could have moved forward with the study and said, okay, I'm ready to test. But I was nervous because I knew the next 6 months he was under a lot of stress at work, and I thought this might not be the right time. And when she told that to me in the session, her husband actually said he had no idea, and that if she had told him, then they could have tested right away and he wouldn't have had a problem with it. After she got the results and she found that she was positive, she said, it's on your mind 24/7. You feel this weight and this burden all the time. I would watch him, her husband, and he'd be watching a football game that he was enjoying, and it's on my mind, and I would want to talk about it, but I would see, oh, he's having a moment that's LFS-free. And I'd be like, oh, he's getting to escape it for a minute, so I don't want to take that from him. So in conclusion, again, there were two types of couple coping that emerged from the interviews. A lot of couples were using this balance or turn-taking process, and that's because there were a lot of stressful events that were going on that required the use of as many resources as they could. For some people, coping alone was easier, especially directly after the loss of someone in the family. They found that they couldn't really talk to their spouses, and it was easier to kind of deal with it alone for a little while. And then again, the protective buffering was bidirectional, and that is unique for this population. Touching upon that, this does come from a place of wanting to protect the partner, but it did make assumptions sometimes about what the partner needed. Overall, the family interviews were viewed as healing, helpful, and insightful. People said that they really enjoyed the facilitated open communication of talking about their experiences, and many of them did ask for recommendations for mental health services. Some implications for clinicians working with this population. It would be really great to encourage people to talk about their stress and help them kind of discuss it together, in whether it's when they come to clinic or when they're at home. Seeing couples together can permit easier collaboration between not just the person with LFS, but the whole family that's affected. And the other thing that patients said that was very helpful was that if they were able to find what they were good at in this process, where their strengths were, maybe some person was really good at managing the electronic medical records, or somebody was really good at scheduling appointments, they kind of found what they were good at, and that made them feel like they had something to do and to take care of. But to really help them communicate about what kinds of instrumental and emotional support that they need. And lastly, it's really important for couples to prioritize the care and the maintenance of their relationship during times of extreme stress. So take time to reconnect, take time to be a couple, go on vacations, and as a therapist, go on date nights. All right, and lastly, I'd like to really thank all of the people who shared their stories with me, and I'd really love to thank all of my team at the NCI and everyone who helped organize this conference. Thank you.
Thanks, Jen. Any questions or comments? A couple up there.
Hi, that was excellent. I am an LCSW and also a person living with LFS and also a founding member of Living LFS.
Wow.
And I've been so surprised through my journey how much people don't talk about this aspect of it, because cancer alone does so much. And then having LFS on top does so much more. But aren't you surprised too that there's been no correlation between Cancer, LFS, and PTSD? Because I see like the recurrence and the waiting for the other shoe to drop constantly.
Absolutely.
And I just, hopefully maybe one day I'll settle down and do it, but I really hope that comes out in the future. But thank you. That was
Thank you.
amazing.
Yeah, that's a great point. Thank you.